Good morning, dear friends. Our today's topic is chronic coronary total occlusion intervention, indication, and what are the current evidence. Myself, Dr. Anand Shukla from Department of Cardiology. We will briefly discuss these are the two aspects, that is the indication and the current evidence. If we go that by definition, the chronic occlusion of coronary artery for more than 3 months with TIMI-0 antegrade flow associated with development of collateral from the donor vessel, either it is a homo or hetero, that maintains the certain level of perfusion at the myocardial level in the CTO related vessels. So the vessels should be occluded for the more than 3 months. So coming to our topic, that is evidence and indication. Before that, I would like to go in the brief history that since the inception of the PTCA, the chronic total occlusion intervention has been tried in 1970 by Rutherford and all American colleagues also, but steerability of the wire and balloon and hardware are the limiting factors. Later, the Japanese operator Kato and developed the retrograde technique and all this newer intervention, wire and microcatheter that help to boost the success of the chronic coronary total occlusion outcome and results. Now we will briefly see what are the trials that are available to support the revascularization of the chronic coronary total occlusion. The main limitation is that if you see, there are some randomized registry and observation study. There are 6 randomized control trials. Start with the revascularization trial that has been done between 2007 to 15, around 200 patients with the CTO-PCI versus optimal medical therapy in the stable angina undergoing the CTO-PCI. The primary endpoint were cardiac MRI assess segmental wall thickness in the CTO territory at the 6 months and the secondary region wall motion in the CTO territory in form of LV and diastolic dimension, LV and systolic dimension, and EF. So if you see the result, there is no difference in primary endpoint and LV indexes, but significant lower MACE at the 12 month in the PCI group, but the MACE was not the primary or secondary endpoint. And in this group, the syntax score was less than 13. Next come to the EXPLORE trial. There is a randomized trial, around 300 patients, same CTO versus medical therapy. STEMI patient with the non-culprit CTO, first STEMI has been addressed, then non-culprit CTO has been addressed. Primary, same the cardiac MRI, LVF at the 4 month. In previous trial, they were assessed the 6 month, here 4 months. And secondary, the infarct size and residual motion abnormality. No difference in the primary endpoint, and LVF significantly higher in the LVF. So if one have opened the LED CTO, the LVF definitely improve. So the both randomized trial failed to show to achieve the primary end result. Next come the Euro CTO trial that was done between the 2012 to 2015, around 400 patients. Here the CTO-PCI plus medical therapy versus optimal medical therapy. So symptomatic patient with at least more than one CTO in the large epicardial vessel, myocardial valve assessed in the case of region. If myocardial LV dysfunction was there, then it will prove that CTO segment is viable. Primary endpoint 12 months, they will change in the health status subscales as assessed by the standard question, and a secondary endpoint is a quality of life, class of angina, MACE, stent thrombosis. Greater improvement in angina frequency, quality of life, and complete freedom from angina with the PCI in the patient who has successfully undergone the CTO-PCI. So procedure success was around 86%. So this is the main registry data. It shows patient will get benefit if properly selected, and definitely in form of quality of life and all these things. Next trial comes the impactor CTO trial. Same but the number of patients are very much low. That is CTO PCI plus medical therapy versus optimal medical therapy. The primary endpoints in this group, only the RCA CTO has been addressed. That is a major limitation of this trial, no other. Primary change in myocardial ischemia of 12 months. Secondary 6-minute walk distance and quality of life. The primary outcome better, significantly better in the PCI group, and the 6-minute walk test, walk distance and quality of life also better in the PCI group, but no difference in the standard MACE rate. So angiographic success rate here also the 83%. Similarly, decision CTO trial, randomized trial around 800. Now the number of patients are increasing. So here also the CTO PCI versus medical therapy, de novo CTO in the large epicardial vessel with the silent ischemia and stable angina, ACS not STEMI. Primary endpoint follow 4 years. These are one of the longest trial follow-up data. So MACE is a death from any cause. Secondary endpoint individual component, primary endpoint bleeding stent related. But result no difference in the group. But however in this 19.6 in medical therapy is switch over to the invasive arm. That may be the one of the bias, because 1/5 of patient medical arm turn out to be revascularization arm. And last randomized control is COMET CTO trial. It is between the 2015 to 2017, around 100 patients. CTO PCI versus optimal medical therapy versus optimal medical therapy in stable angina with proven viability. The primary endpoint assessed at the 275 around 1 year, and the secondary all-cause mortality. The significant improvement in all 5 quality parameters in CTO PCI group, and no difference in the secondary endpoint, and PCI success rate around 94%. So among all 6 randomized control trials, if you see the hard point, the primary and secondary hard point are failed to achieve in majority, but if the patient has been selected properly, patient quality of life definitely will improve as per this trial information. Now come the observation studies. These are the single center or multi-center. Jones et al. Observation study between the two. So this is the earlier. As the later part of decades and recent, more and more improvement hardware, the success rate has been improved. So here the CTO success rate around 70%. They have compared the observation study, majority have compared the successful versus unsuccessful PCI. That they found that the significant lower rate of all-cause mortality, target vessel revascularization need for CABG in the successful. Similarly, Borgia et al. Observation from 2003 to 2009, around 300 patients, same comparison successful versus unsuccessful PCI, median follow-up of 4 years, significant reduction in the MACE, mainly driven by the rate of target vessel revascularization with a successful CTO PCI, less physical activity limitation, rarer angina frequency, greater treatment satisfaction. So, and last few remaining the observations, if you come to the last few, George et al. Observation study between 2005 to 2009. It is a British database. CTO PCI, stable elective patient with CTO undergoing PCI, median follow-up 2.6 years. The results show significant improvement survival in successful CTO. So all observations study one result consistently find the improvement in quality in successful PCI patients. Procedure success around 60 and DS were used in 82%. Then Mehran and al. There is same early trial of 1998 to 2070, total 1700 approximately patients, 3 tertiary care centers, successful PTCI were unsuccessful PTCI. Shows the same significant lower all-cause mortality, cardiac mortality, CABG in successful CTO PCI versus unsuccessful CTO-PCI arm. The MACE significantly lower in the DS versus BMS as expected due to lower target vessel revascularization. Median follow-up around 3 years, procedure success 68%, DS in 65%. So even though the observation study are the more biased for the patient selection, but one result has consistently proven that the successful CTO carries the good quality of life. Similarly, Goyal, that is from our where I studied from SGPGI, observation study from India, around 550 patients, successful PTCA of CTO versus unsuccessful CTO PCI. The primary endpoint significantly better in the successful CTO PCI group and no difference in secondary endpoint. Secondary endpoint where compare death, MI, repeat revascularization. So the death, MI, repeat revascularization not difference. Similarly, Tomsello and Park et al. All have compared the CTO PCI versus CTO PCI versus OMT versus CABG in the Tomsello et al. In the 2008 to 2009. In that, the result shows the significant higher rate of death, MACE in OMT and CABG group, higher rate of stroke in CABG, higher rate of acute MI and hospital in OMT group. And CTO PCI does carry the good outcome. The last, Park et al. From Seoul, around 1500 patients CTO PCI versus OMT. This is the only last two observation study compared with the OMT. These are the primary aim was randomized control trial. The primary, the cardiac death at 10 years, secondary all cause death and acute MI anyway. Primary and secondary endpoint significantly lower in the PCI. Also the propensity score matching. The cardiac death and all cause death significantly lower in the successful versus failed CTO. So from the study we can conclude that if the judicially use the CTO intervention with the high possibility of pre-procedure success rate, then definitely patient will help. We will help the patient by opening the CTO. So come to the basic question, should, because not a randomized trial shows the significant improvement. So come to the basic question and its answer, whether we should open the CTO or not. What we offer the benefit to the patient, definitely symptoms, definitely ischemic burden and the myocardial function as we observe in the randomized control study. Technical success, it depends on different J score, progress CTO score, ambiguity of cap, length of cap, calcification, duration and operator experience. So these are the factors that can influence the outcome, successful or unsuccessful outcome of the CTO. Now what are the risks involved in the opening the vessel? So depend on the age of the patient. If the elderly, then definitely yes, and the longer lesion, definitely yes. And long-term complication after successful opening the CTO is the instant stent thrombosis and need for the repeat revascularization. And report long-term DAPT required because it is a complex procedure. So if we go by the simple algorithm, if patient is a clinical evaluation, suppose patient come to our clinic and say whether we have to assess whether symptomatic or asymptomatic. If definitely symptomatic, then we have to assess by ECG, echo, basic investigation whether the area of interest, the area of CTO is viable or not. If the area of CTO is akinetic or dyskinetic, then we have to go for the SPECT, cardiac MRI or PET to assess the whether viable or not. If it is non-viable, then we go advise the optimal medical therapy. If it is viable, then we directly go for to attempt the CTO. And if patient is symptoms are ambiguity or asymptomatic, but major vessel involved, suppose left main or LAD and EF multivessel or EF is less than 35, and if the cardiac MRI viability shows the ischemia is more than 10% reversible inducible ischemia, then PCI would be the advisable. If is no inducible ischemia, then PCI is not advisable. So the CTO of the large epicardial, these are the table taken from the Euro intervention. History of Q wave, RWMA, yes. Then cardiac MRI, assess the viability. Yes, if it is viable, then CTO recognition is very advisable. If non-viable, then medical therapy, and viability test is inconsistent, then also we consider medical therapy. Symptomatic, yes, then the CTO recognition should be considered. So basically the symptoms and viability decide the indication of the CTO. So current recommendation. In past, the CTO revascularization received the punitive treatment in guideline. They are considered the contraindication. They taken the result, the OAT trial. However, so in first ECS guideline, which inappropriately applied the negative result of the multicenter OAT trial, this unjustified discrimination has been removed from the most recent guideline. So if we go by the guideline, the European showed two CTO revascularization 2A indication, American guideline CTO indication 2B. So as per European guideline, percutaneous revascularization CTO should be considered in patient with the angina resistant to medical therapy or with a large area of documented ischemia in the territory of occluded artery. While in Americans, in a patient with the suitable anatomy who have refractory angina on medical therapy after treatment of non-CTO lesion, benefit of PCI of CTO to improve symptom is uncertain. So they have still considered 2B for the CTO revascularization. Though the CTO program now has been very well accepted in all over the America, also many operators are doing the CTO complex procedure. So what take-home message and what we learn from the SIRE trial? Symptomatic or asymptomatic CTO of major epicardial vessel with the viable myocardium territory of the CTO segment and angiographic good success rate with should be attempted with the dedicated or trained expert of CTO operators. As we know from the trial that outcome of successful CTO is better than the unsuccessful CTO. In Japan, they have done the trial of CTO opening with the expert versus trained CTO operator. But they have shown that there is no difference in the outcome. So means who are intended to work in the CTO subspecialty can attempt the CTO. In our center at UNMICRC, symptomatic patient on medical therapy remains symptomatic despite of optimal medical therapy. We attempt the CTO vessel revascularization after confirming the viability. Thanks.